Hello and welcome everyone for tonight's EAO Just Ask. We're back from our, I would say, a little too short summer break, but we're here again for a hot fall, and we're starting with an amazing topic, an amazing expert, and an amazing friend. But first of all, as you all know, our annual Congress in Monaco, it will be in 2 weeks. So everyone who has not been linked into our Congress, who hasn't subscribed to our Congress, come there. It's an amazing program with the top-notch experts. And one of our experts in Monaco will be Professor Jan Cosyn. Professor Jan Cosyn, haven't you read that? That's the guy who's sitting in front of his screen and listening to me, and we are all looking forward to your content. Jan, it's a great pleasure. Thank you for accepting the invitation on behalf of the EAO. We've done so many projects together from a scientific perspective, also from a clinical perspective. We laugh together. So it's just great to have you. Thanks for doing this with us, and so shortly before the annual Congress to see you in a digital way. So thanks for being here.
Thank you, Stefan, for the nice introduction. Thank you, the EAO, and especially you for inviting me here to be able to talk about one of my favorite topics in implant dentistry. I'm especially happy that you are my host because we go a long way back. So I think we feel at ease both.
That's true. So just to briefly introduce you, I think everyone knows you. By the way, you are also one of the chairs of our annual Congress. So everyone who has another question, which we cannot attach today to you, can come up to you in Monaco. So you will be one of the chairmen, and you will also take care about the program in part. So you are one of a top-notch expert when it comes to implant dentistry. In particular, your favorite topic is immediate implants. I mean, you published so many papers. I would say you published so many landmark papers in their perspective, which brought so much to our community in perspective of immediate implant placement. You're the chairman of the University of Ghent, of the perio department and the oral implantology department. You published so many articles. You're also in your private office. You published a lot of the systemic reviews. So who else than you should we invite when it comes to immediate implants? And Jan, it is a little bit a controversial topic because if you look into social media, you sometimes think immediate implant placement, anything goes, right? What do you think?
Yeah, that's the impression that I got. I also have I share the same feeling here, and that's why I think tonight may be important to open some indications, but also to shut some down, I think, because we can do it in certain situations, but not in all situations. And it's important to make a comprehensive diagnosis, I think, in order to treat more patients in a better way.
Totally right. I mean, yeah, and there are already a lot of people logging in from Spain, from Norway, from Turkey, from Switzerland, from Italy. So they all want to hear your content. But Jan, actually, a case came across me. And I thought twice. I placed 2 implants. It is the aesthetic zone. I actually, when drilling for the implant, I thought about you. I don't know if you felt your ears scratching. I thought, should I do it or should I not do it? So Jan, just this clinical picture, what do you think? Thumb up, thumb down? What did I do? Was
Somewhere
that
in the
wrong
middle,
or was that
Stefan.
right?
Somewhere in the middle, let's say this.
Okay, what is your take?
Yeah, well, I think the implants are properly placed here. No discussion about that. But I see the bone, and this is something that we need to discuss here. I see the bone, and I hope this is not an aesthetically demanding patient, because that may backfire if we do that all the time. And allow me to go through some guidelines with respect to surgery in immediate implant placement to avoid complications, because this is the topic of today.
So thank you for these words. I mean, I already thought when I placed these implants, you're gonna say this. But anyway, this is why we're here, to know, to get to know the scientific content, but also your clinical expertise when it comes to these cases. And I think you already outlined, guys, be careful. This can be dangerous. So, Jan, I know you prepared some content for us, and we're so much looking forward to hear that content. Normally, it's a little bit the tradition of this Just Ask that I go just in between your slides and ask you a question. It's not unpolite. It's just good for the viewers, for the auditorium. I think it's nice if I get questions from you from the YouTube chat. I will see this. Just type in your question. I think Jan is more than happy to answer them. So Jan, we're so much looking forward to your content. Please, we are happy to hear your content.
Do you see my presentation?
Perfect.
It's on screen. Okay. So I would start off with a clinical case, 60-year-old female patient, as you can see here, with a root fracture on tooth 12, and you see the corresponding CBCT images on the right side with the arrows really delineating the dehiscence in the vertical and lateral extent. Now, before we go into details on this treatment of this specific patient, I think it's important to highlight a little bit where we are today in immediate implant placement. So the state of the art in, let's say, straightforward cases. And I would guide you through some systematic reviews that a lot of amazing people in my group have published. So all the credits for them, because I was just the instigator, but they did all the work. For instance, Jeremy Pittman is one of them. And he published a systematic review on comparing a flap to flapless approach, showing basically that when you do not reflect the flap, you have 0.5 millimeter thicker buccal bone. So since we have access to the buccal bone while extracting a tooth, I don't see any reason anymore just to make a flap to visualize the bone. And that's the case that you brought with you. So that's one thing to remember. Now, one of the, I would say, top-notch systematic reviews of this year is this Swiss study, Chiavon, basically showing that computer-assisted implant surgery is much better than freehand placement in immediate placement. It's one of the few studies, systematic reviews, specifically on immediate placement here. And it showed that freehand placement, results in over 3.5 millimeters of coronal deviation. I think in immediate placement, it's the coronal deviation which is important, not so much the apical one, because the coronal deviation will determine whether it will be an aesthetic success or a failure. So, guided surgery is really a must in every immediate implant case in the anterior maxilla. There is no doubt about that. And this all comes down to, in fact, perfect implant positioning. You can discuss a lot of things in immediate implant placement, but you can never, let's say, compromise the perfect implant position. This is the only rule set in stone. And for that, I developed, let's say, three zones, key zones, which is called the safe zone in green, the danger zone in orange, and the red zone is the failure zone. And you see that the safe zone is quite narrow. And the danger zone is even narrower. It's only 1 millimeter in the horizontal dimension and 2 in the vertical dimension. So if you have improper implant placement, you will have easily complications, even in a type 1 socket where you have an intact buccal bone wall. Now, I don't have the time now to go into details on this, but you can find that detailed information about these three key zones and the biological reasoning behind them on my professional Instagram account. So if you are interested in such account, you can access that.
Jan, can I have a quick question? If I look at your zones, I mean,
Yeah.
how important is the diameter of the implant? Because I can pretty much go out of your danger zone when I just small the size of the implant. Of course, if
Yeah.
it's in the right indication, of course.
Yeah, that's a pretty good remark because we need to adapt the diameter of the implant in order to stay into the safe zone. So we will use reduced diameter implants in the anterior maxilla just to make sure that we are there to avoid complications. And this goes back, 20 years ago, we were trying to fill the socket with an implant. But this we know today that this is totally wrong.
But
So
this still could mean if I use a small diameter implant, if I maybe have a platform switch with it, I may have to place it deeper in order to get a nice prosthetic emergence profile. Or where do you see the border for this problem?
well, the vertical issue is the following. Your implant needs to be placed exactly 4 millimeters away from the soft tissue margin in order to make room for a perfect emergence profile. I will come back to that a bit later on. So this is the vertical dimension. In the horizontal dimension, you just adapt the diameter, but you need more than 2 millimeters of buccal bone gap. That's the minimum. I would say more than 2 in a standard situation, but later on we will see if you are dealing with, like this case, a buccal bone dehiscence, you need 3 or more. So there is one important difference here because the regeneration chamber is much more complicated and you need space for that.
Yeah.
Oh, okay. So then a third one comes from Lorenz Seysens, another student from my group. Should we fill the gap or not? I think there is no discussion anymore about that. Yes, of course, we need to fill it. We need to fill it every single time. I do it with a DBBM. That can be particles, that can be a collagenated DBBM graft, what you see here on the screen. But when you are dealing with an intact socket, it doesn't really make a difference what you use there, granules or just a fixed graft or moldable graft. Later on, there may be a difference. But anyhow, this systematic review showed that if you do the socket grafting every single time, you have thicker bone and you have less midfacial recession. So I think the scientific community has come to support this as a, let's say, standard of care.
Jan, I always still have a question. It's so interesting. I'm sorry, but so if you say now we're going to fill the gap, and let's say we don't have a dehiscence, so we have 3-wall bone defect, but as we look into our studies, we might know that at least a certain point of the buccal bone plate is going to resorb.
Absolutely.
So what do you believe is going to happen with these bone particles over time? Will they already be bone when the buccal bone has resorbed? Do you understand my question? Or will it have like particles in soft tissue?
Yeah, well, sometimes when I want to say it like that, sometimes we have an implant failure from time to time. And that allows me to go back and to install another implant. And I'm always amazed that when I feel then the buccal bone wall in those specific cases, most of the times I have hard, healthy bone there up to the level of the crest. So maybe we don't have histology on on a lot of cases, but I'm sure that if you give it some time, it will mature, and the vast majority of that buccal bone wall will be mature bone. If not, at least it holds up the area, the volume, and for aesthetic purposes, I think it will do the trick.
Like, for example, as we do it in peri-implantitis cases, right? It probably also not be in re-osseointegration, but it holds up soft tissue and stable.
Yeah, we also have some isolated cases where we don't have a buccal bone wall anymore, but there is no pocket, and we have thick connective tissue due to connective tissue grafting. It's perfectly healthy, and probably we have there collagen fibers attaching onto the rough implant surface.
Got it.
It's not what we are aiming for, but in worst case scenario, it still works quite nice clinically. Yeah. Which brings me to the connective tissue graft. And you know, let's say in the last 5 years, we have more the discussions on this. When it is needed, what is the added value? We know that it reduces recession, so it contributes to soft tissue stability. Should you do it every single time? Probably not. We postpone it in premolar cases, but we tend to do it as a general rule in central incisors, lateral incisors, and cuspids, you know, because this is an aesthetic priority there. And for me, that's reason enough just to provide the best possible treatment that I can give the patient. And then finally, again, Jeremy Pittman, provisionalization. I think this is also of crucial importance because it contributes to the soft tissue architecture, which is there from the start, and it provides or it supports wound stability at the same time. And of course, it gives the patient an immediate tooth. So why not? I don't see any reason to do an immediate placement if you don't combine it to an immediate restoration concept. To me, it doesn't really make sense. And there is scientific support to do that, although I must say that the number of studies in this specific field are quite limited. So there is some bias to that.
But Jan, what is then your personal take? I mean, we already had just asks about the provisional restoration, the contouring. We had, like, say, not opposite opinions, but with people saying be as slim as possible. Then we have people copy the natural emergence, and we have even people saying go convex to not lose soft tissue or lose the emergence. What is your take? You said there's not too much research, but what is your clinical idea?
I think it's none of the ones that you described now. It's a mixture. And I will come to that in a few seconds because I have a great slide on that, on the morphology of the emergence profile. And there is a convex zone in there, there is a concave zone. And most importantly, the vertical dimension of the abutment is of crucial importance to preserve the bone at the same time. So there is some research on that. But it's from a clinical perspective, it's kind of key importance, I would say.
Yes.
Now, I have good news and bad news for you, Stefan.
Oh.
Would you like first?
Let's start with the good news always.
Oh my God.
Maybe the just ask, the time is already up then.
Now, do you realize that you belong to the 10% of people wanting to hear the good news first? 90% want to get rid of the bad news. Let's have it.
Okay. So
let me rephrase the question, Stefan. What do you want to hear, the good news or the bad news?
Okay, let's go for the bad news.
Okay. Now, Aksa Likrot is one of my other students. Is an amazing lady, very enthusiastic, and she did another systematic review comparing, in fact, the outcome of intact buccal bone walls and dehiscent buccal bone walls. It's not that easy, but anyhow, she found 20 studies, and these are case series, randomized controlled trials, cohort, whatever we could find. Now, out of 20 studies, only 14 applied a flapless approach, which is 70%. And now this is really astonishing. Only 6 applied a guided approach, the use of a stereolithographic surgical guide, which is really, really low, I would say.
Yeah.
Now, the inclusion criteria was that every study had to perform socket grafting. So this is 100%. This is, let's say, what I consider standard of care. Then we have the connective tissue graft, 30%. And then there we have the immediate provisionalization. But I hope you realize that these are just fragments of what we should be doing. And if we combine all of them, it should not be surprising that only 2 out of 20 studies, this is 10% of, let's say, basically the literature, which is actually applying the state of the art as we know it today. So the level of evidence is in immediate implant placement is not really where it should be. We have a lot of studies, but not top notch. And I include a lot of studies which we did on our own. I have to admit that. But okay, this is maybe something to add to universities or people trying to do studies. Now, what was the vertical dimension in this systematic review? Well, it went from 3 millimeters up to 10 millimeters. And we couldn't really identify what the vertical dimension was in one study versus another. And nobody talked about the lateral dimension. Actually, nobody. So it was never reported. And this is really surprising. Now, I promised you good news. The good news is that we have 2 studies, 2 controlled clinical studies that have identified risk factors for recession. We can talk about the buccal bone, which we will do in a minute, but I think for the patient doesn't care about the bone. The patient cares about the aesthetic outcome, and one of the main features is the soft tissue level. If we have recession, I think a lot of patients may consider it a failure, especially when it is over 1.5 millimeters. And then it's a failure. Well, a buccal bone dehiscence is a true risk factor for that. Lee has shown that, and we have done that in another study. So isn't it beautiful that 2 studies from 2 different groups, they actually show exactly the same outcome.
But these are good news for you.
This is good news, yeah. And then the second risk factor is the thickness of the tissue. So I would say I'm a simple guy, you know. This is easy to remember. Look at the bone and look at the tissue. And if you have one or both, you have risk. If you have both, this is really high risk. And we should think about that in treating the patient. Now, why is it?
So can I nudge in here for a second?
Yeah.
So if you look into the literature and also your clinical expertise, could I sort of overcompensate with the other tissue, maybe a dehiscence, let's say overcompensate with soft tissue, a buccal bone dehiscence, and vice versa? If I have a thick bone, could I maybe just leave out the connective tissue graft? You get my point?
You're a smart guy, a smart clinician, Stefan. I think that there is something to that. Yeah, you can compensate, and the thing is, the risk here is the recession, the facial recession. The question is why? Why is this risk higher in a dehiscent case versus in an intact socket? Because the dehiscence itself, it compromises, in fact, the structure of the wound, of the healing compartment. And at the same time, we have the osteoprogenitor cells that need to, they need to come a long way to repopulate that area. And here we see a quite complex dehiscence because it goes around the corner, you see? You see there the distal side or aspect of the root. So the dehiscence goes around the corner, and in such a case, the regenerative potential is substantially reduced.
Yeah.
Now, there is one, I think, beautiful classification on the vertical extent. And if you go to the literature, I think you find approximately 10 classifications. I want to be absolutely clear. Forget about the other 9. Why? Because they don't have any therapeutic impact. But this one has a therapeutic impact. And that's why it's important to use this one. So the vertical extent, it goes from a 2A to B to C. And you see there the numbers. If the dehiscence in a vertical dimension is less than 4, it's a 2A. It's between 4 and 6, it's a 2B. It's over 6, it's a type 2C. And then you have the type 3. And the type 3 is a case where you have recession on the tooth. Now, I would already like to stress that this is a no-go for immediate placement in my hands. Because from a biological point of view, we have a major problem. Why? We cannot secure wound stability because of the recession. We have the recession on top of the dehiscence. And of course, you could coronally advance the flap, but I don't want to do that because also that compromises wound stability. So it's a no-go. Whenever you see a recession on top of the dehiscence, forget about it. Now, the vertical extent is one thing, but from an aesthetic point of view, the lateral extent is much more important. Because this is in close proximity to the soft tissues. And apart from Joseph Kahn in 2007, nobody is talking about this. Actually, nobody. But you realize that a buccal defect has more regenerative potential than an interproximal buccal defect. And that a bit more than an IBI defect. It goes around the corner on both sides. And then you have the extended defect. The extended defect means that you have bone loss on the adjacent tooth. Again, this is a no-go. Of course, you can place an implant there, an immediate implant, but it is absolutely not predictable how the tissues will react in that interproximal aspect there. So I think we need to go for more safe approaches there, and it's not an immediate implant. So we are preparing, I'm kind of excited about this paper. It's nearly ready for publication. It's a paper on the morphology and of all these defects and on their therapeutic impact. So it will be an open access paper ready for everyone to read it easily, because I think it's not based on clear data, but it's based on biology and biologic reasoning in clinical practice. Now, if we combine the vertical and the lateral, in fact, we have 9 possibilities. We have here the type 2A sockets combined with a buccal aspect, IB aspect, and IBI. And the same applies to the type 2B and the type 2C. Sounds complex, but in fact, if you combine the two, this is what you get. And these green possibilities are, I would never say easy, but I would say they are manageable in an advanced way. It is a complex case anyhow, but we can overcome it in a quite straightforward way. And then we have these 2 types. It's the type 2B-IB, where the vertical extent is a bit higher up, 4 to 6 millimeters, and it goes around one corner. Or the type 2CB, that means it is a quite narrow defect, but it is very, very high.
I mean, Jan, just to just go in here for a second. I mean, in these cases, people will probably tell you, okay, so what? Then I just place my implant deeper. I have a conical connection. I maybe work with a mesostructure. You sometimes see this. They put in mesostructures intraoperatively and work on tissue level. I mean, what is your take on this?
Well, the thing is, if you don't treat it properly, especially these orange cases, these delicate cases, you are in for a disaster, potentially, because you don't know how the tissues will react.
Right.
Especially if you don't combine it with a soft tissue augmentation, for instance, where you somehow could compensate for the loss of hard tissue. But you have to make a comprehensive diagnosis first in order to treat it properly and to avoid complications.
Because, so just to make it clear, what is your take on just placing the implant deeper?
No, I always place it at 4 millimeters depth. regardless of having an dehiscence or not, because the implant position is sacred.
Got it.
We have we know how to place it perfectly, and it doesn't depend on the fact whether we have a dehiscence or not. Absolutely not.
Very good statement.
And these are, I would say, the complex 2.0 cases. Yeah, I don't want to give the message that people are doing this tomorrow morning, these cases. Potentially in the future, we can do that, and we will develop treatment concepts for that. But at the time, I think it's important to stay a bit on the safe side. And you see, we have here 9 possibilities. We have already 3, 4, 5, 6 possibilities, 6 scenarios that are quite amenable for immediate implant placement.
And I mean, Jan, let's be honest. I mean, these orange cases, they are demanding in a delayed fashion too. I mean,
yeah.
How could we do it in an immediate way?
Yeah, that's true. So anyhow, we are in for complex treatment, no matter what we do. In an immediate, early or delayed mode, it doesn't really make a difference. But if you do it in an immediate implant placement procedure, you increase complexity beyond any doubt. Now, the example that I have shown you is this one. It's a type 2B IB socket. It has a vertical extent of 5 millimeters of bone loss, and it is, let's say, partially contained. It is contained at the medial aspect, but the defect goes around the corner at the distal aspect, so partially contained. Now, this is the scheme for the type 1 socket. It is advanced, let's say. What should we do if we have a compromised socket? Compromised being defined as whenever we have a dehiscence, no matter what its dimensions are. Well, the first thing that we adapt in our treatment approach is the buccal bone gap. I will aim for a wider gap, 3 millimeters, which is logic because there is no bone there. So I need to replace that buccal bone as well. But I need some safety zone in that regeneration chamber to make it more predictable. So 3 millimeters would be what I'm aiming for. And then, depending on the type of dehiscence, I will use a membrane. In this specific case, I used a membrane, which is not that easy. It's a collagen membrane because I don't want the membrane in contact with the connective tissue graft. So it needs to end up higher, 3 millimeters higher up. And you can suture if you want when you apply the bone grafting material. Now, remember I said you could use particles to fill the gap. I think here in this specific case, it's better to use a collagenate DBBM graft. It's moldable, it gives structural strength to that compartment.
Jan, if you use the membrane, do you slightly flap the area beneath the dehiscence to tuck it under it, or how would you apply it?
No. I don't think it has no use because it's not rigid anyhow. It's like a piece of paper, You cannot expect structural strength from this membrane. So why would you put it under, let's say, a pouch that will compromise the stability of your wound? If you do that, I can live with the fact that you do that apically, but you should never do it coronally. Not in the coronal area, you leave it attached.
Because you say it's detrimental for wound healing.
Yeah. You just use the membrane here to keep away the connective tissue from your bone replacement graft. So you can have, let's say, ossification without the interference of soft tissue.
I mean, we see people using more stiffer membranes to have more rigidity. Do you think this has any added value?
Yes, when you are treating, let's say, type 2C sockets with an IB component or an IBI component, so the very delicate, complex cases, should be treated with a rigid membrane.
Mm-hmm.
Absolutely. But now I'm talking here about the specific case where I started with. I would use here a collagen membrane, which is
got it.
Yeah, quite easy. But you see, if you treat these very complex cases, you need other materials which are more difficult to handle, which are more prone to possible complications and so on.
Of course.
So it's not impossible, but you enter more into the question area. Now, when it comes to soft tissue surgery, when you have a dehiscent case, I think you should do an all-in-one surgery. If you have an intact buccal bone wall, we have studies on that, you can choose. Or you do it at the time of implant placement, or you come back after integration and you do the soft tissue grafting. It doesn't make a difference. However, here, the soft tissue graft helps you to close the healing compartment. So I think from a biological point of view, it makes sense to use that benefit and to do it all in one procedure. And for that reason, I will need 2.5 millimeters of a scarf connective tissue graft. So not too deep, because I don't want to compromise the bone healing. So a superficial scar of 3 millimeters, which is placed in contact with the connective tissue graft at the inner part of the socket.
Okay. Does it play a role if it's a classical harvested connective tissue graft or if it is deepithelialized?
I always take a free gingival graft and I extra orally deepithelialize it.
Got it.
But yeah, it's what I do. There is no hard scientific data on that. In fact,
you could assume that it's a little bit more rigid, right?
Yeah, I think so. Yeah. The way of deepithelializing this.
I also hate this word.
Actually, sorry. It's not important.
Okay.
Probably not. But you could opt for a single incision approach also. Whatever you want, but it should not be too large in the vertical dimension. So this is the treatment scheme for the type 2B IB socket and the type 2 CB socket. But for sure, it is complex in the SAC classification. Now, to come back to the case, we have here now the intraoperative view of the implant in situ. We have inserted the membrane, we have secured it, and we have here a couple of sutures placing this connective tissue graft in place, keeping it in place, and in fact closing the compartment. This is a very nice paper from Marcus Blatz and colleagues. It beautifully shows, it's a bit of a, let's say, philosophic paper. It's not based on real data and numbers, but I think it's crucial importance for anyone who is doing immediate implant placement. But because it's not only about the implant, it is more and more about the morphology of what comes on top of that. And you can select a lot of implant systems. They will do the trick. They will suit it. They will be suitable. But I think you need to make a conscious choice in your implant system based on this, on the available height of prosthetic components, on the abutments. And what is crucial is that you need a C-zone, which is more than 2 millimeters in order to preserve the bone. And then we have a concave bounded zone, which is the B zone, and then a slightly convex aesthetic zone, the E zone. And if you apply that, this is, with this morphology, you will perfectly support the soft tissues, the hard tissues, and you close, in fact, that critical regeneration chamber.
Yeah, and does the height of the tie base play a role? Sorry for these questions, but it's so important, and you're top notch. I mean, does the height of the tie base play a role, or just use a regular provisional base?
No, it should be more than 2 millimeters. This is, for instance, the Stroman. It's 2.5.
So this is your C zone, the tie base.
Yeah.
Okay,
this is
got
the
it.
tie base. It's the C zone. So when you add all these zones, you have perfectly 4 millimeters.
Got it. But that's a very important information. So pretty much the C zone is the height of the thigh base.
The height of the thigh base, yeah.
Yeah.
And I see also on social media, I see too much 1 millimeter high base, 1.5. I'm sorry, it's too short.
Yeah.
It's not biologically, it's not good enough. So we should try to place them perfectly, 4 millimeters, and then you have 2.5 for the C zone, 1.5 for the concave bounded zone, and 0.5 millimeter for the aesthetic zone.
Perfect.
And that's 4. And if you apply that, you will never run into troubles. So this is the result. After 6 months, it's still the provisional crown. You see perfect architecture, symmetrical view. You have the papillae there. You have the midfacial level there. It's fully supported and stable. Now, I picked this case because I did a sinus lift in this patient in position 27. And I had to come back with another CBCT, which allowed me to see what happens there after 6 months. And you see there the implant, you see the thigh base, and you see, is it bone? I don't know, but it looks like bone. We have thick tissues, soft tissues, and it looks like a very decent buccal bone wall, which is maturing. So I feel quite confident that in this type 2B socket, we have had success by applying a very rigid treatment approach, which in fact is based on no flap, which is based on securing that regeneration chamber.
And it seems to tell us that this myth that the bundle bone has to go biologically is not true.
Well, it depends on the thickness of that bundle bone, of that bone wall. I'm sure that, let's say the cervical area, it will go. We have the studies for that. But basically, that's not that important. I think we need to look for stable tissues there. Whether it is bone, soft tissue, preferably a combination of both. But I think we owe the patient to give him or her stable tissues from an aesthetic point of view and in health. So if I conclude, well, some buccal bone dehiscence, they can be managed with immediate implant placement, but unfortunately others cannot. And the crucial step is to discriminate between these cases through comprehensive diagnosis. And remember, safe zone, danger zone, failure zone. The position of the implant, whether you have a dehiscence or not, is of pivotal importance. Now, the lateral, especially the lateral, I should have underlined that, the lateral and vertical extent of a buccal bone dehiscence, it determines the regenerative potential of a case and thereby its therapeutic approach. There is no single regenerative approach for every buccal bone dehiscence. It doesn't exist. You need to adapt the treatment according to the morphotype. So, and then finally, immediate implant placement in a compromised socket is always a complex treatment, always. So it requires expertise and skills, and it's up to you as a clinician to judge whether you have that or not. But I think start with quite easy cases, start with type 1 sockets and see where that brings you and apply all the 5, let's say, guidelines that I've shown today to bring you to a predictable outcome. And if that works, maybe then it's time to do the next step. Stefan?
Yeah, that was amazing. I applaud you. Chapeau to your work. I mean, it's amazing what you do on a scientifically based thing, but also from a clinical perspective. I mean, how structured you are, So congratulations to your work, and even more great papers coming up. I could only make my lectures with citing your department. So that's pretty much it. So congratulations, people applaud you in the chat. I mean, it was a great lecture. Thank you very much. Thank you very much.
Thank you.
If you have time for some more questions, we have questions coming in the chat. So if you have more questions, please just type it in. We have a question from Andri Halson. How the placement 4 millimeters under the gingival level, you said you're quite strict with that. And I would like to ask you one more question onto that topic because I thought it's interesting. He says, is that the current gingival level, or is that the gingival level you assume that the situation will end up?
Well, you basically aim for full preservation.
Yeah.
So when you select a case, you start with a case with a perfect soft tissue architecture or a small recession, but then you have to deal with a type 1 socket. Yeah. If you have a dehiscence, any recession is a no-go. And then, of course, I know if you apply it decently, properly, then you will, most of the time, you will have some gain in soft tissue level in a lot of cases. But this is luxury, you just push it a bit up and you are where you want to be. So yes, you just measure it digitally in your planner, 3D planning software, and you know exactly where 4 millimeters is, and you just execute it clinically. You just do that. You just follow
Great.
that.
There's a question from Per Oscar Otterstad. Thank you. How about the graft? I mean, should it be DBBM material? You sort of elucidated on that, how important it might be in a dehiscent case, or could it also be autologous bone?
Yeah. We use autogenous bone, a mixture with the CDDBM in very, very complex cases where we need a rigid membrane and where I want bone formation from the graft itself. So yes, autogenous bone is good because it initiates bone formation, but I will never use it for 100%. Because it's too resorption sensitive. We know that the DBBM has perfect features on that. It has perfect quality in maintaining the volume. So I would say never change a winning team,
Got it. And let's say the most scientific documentation we have on DBBM materials, right?
Yeah, absolutely, beyond any doubt. Yeah.
There's another question on the length of the implant. I think this is an interesting question because how do you choose? Because we talked about the diameter and now it's a question to the length. I mean, how do you choose the length of the implant? Is just this a matter of primary stability, or what is your idea behind choosing the right length?
I would say as short as possible, but as long as needed. And usually it depends a bit on your brand, your implant brand, but most of the immediate implants now have a length of 12 millimeters. Sometimes 14, but I like to avoid the 16.
Also depends a little bit on the architecture of the socket, right? If you have a socket which is sort of going all the way in your maxilla or your mandible, you might have to anchor it apically, right? That could be also a decision about that.
That is also comprehensive diagnosis. You need to be aware of that before the surgery. So you need to plan the case, and then you know exactly where the difficulties will be and what the possibilities are there. So yes, you need to have an anchorage at the palatal and the apical bone. And to be on the safe side, you might say, I need 4.5 millimeters of apical bone, but we push the limits a little bit. If you have 3, sometimes it's enough. It also depends on the bone quality there.
Yeah. There's another question. I think we already scratched this topic. Maybe you can say 2 sentences about this. Does this sort of connective tissue graft play a role? Could it be tuberosity? I mean, we see papers sort of talking about tuberosity grafts in immediate implant placement. You already scratched on that a little bit. Does it play a big role for you?
Yeah, I never do that, to be honest. I always go to the lateral palate, the first molar or second premolar area. But if I have too much rugy there, I always go for the first molar.
Got it. One more question, but this opens a completely new topic. What would you do if you don't place the immediate implant? Would you do like a socket grafting or GBR in an open fashion? Maybe just two, 3 sentences about that, yeah.
Yeah, it's a very good question because one of the few reasons why an immediate implant cannot be done is the lack of apical or palatal bone. If you don't have the possibility to anchor the implant, even if the buccal dehiscence is quite small, it's a no-go. And then, of course, we proceed with an alveolar ridge preservation procedure, which is, from a biological point of view, not that different. But we have the luxury to come back and to adapt and maybe to augment a second time. And then we see that we have bone formation, and the issue of finding primary stability is no longer there anymore. So yes, we need a backup treatment, and the alveolar ridge preservation, in fact, is the only backup treatment.
John, there's some more questions, but I will just give you one more, and I will come back to one of my questions from the beginning. And I thought this is a good question from Chris Chan. Should he use we talked about the tie basis, right? Should he use the straight or convex shape? I think you already answered that with the C shape. Should rather be slim, right?
Should rather be slim, yeah, and concave, not convex. Yeah, there is a very nice study from the Zurich group, Siegenthaler, and Franz Strauss, demonstrating that if you have a convex emergence profile, obviously you push away the tissues. But it has now been shown in a decent study. So we don't want to push away the tissues, we want to preserve them. And then we have to adapt, of course, the morphology of the provisional restoration in a decent way.
Yeah, amazing. I mean, your work is so amazing. We could talk for another 2 hours. I want to go back to one of my questions. You really figured that it made me sort of think, because I always see a lot of people sort of placing the implant just way, way, way deeper and telling me, well, we have such a tight connection. I go for one abutment one time, I graft over it. I think you were very, very, very clear with your 4 millimeters, but would you again stress this? Because I think it's of utmost importance. Why is it not a solution just to place the implant deeper?
Because it's not biologically sound. Of course, you can place the implant 10 millimeters deeper. And of course, there will be no bone loss there. But realize that you are creating a very, very deep sulcus there, which is not biologically sound. So it's not all about the bone. You need to have a perfect position to keep the bone, but at the same time, to keep the tissues and to make it, to keep it healthy. And then I would say, 4 millimeters is really, it's really the distance that you need. Not
Thank you very much. And I hear the periodontist speaking out of this again a little bit. Jan, that was amazing. The people, they all applaud you. You will see the chat later. I want to thank again Professor Jan Cosyn for taking this time. It was amazing, Jan. Everyone loved your content. We really look forward to see you in Monaco again for everyone.
One thing. One more thing.
Yeah.
One of my colleagues from the department, Thomas de Bruikere, he is giving in Monaco a lecture on the C zone, the B zone, and the E zone. Now he is really outstanding. I'm sure you have to go there. He will give you a lecture with tips and tricks in Monaco. I think it's on Friday.
Yeah. I also know him very well. I mean, I visited you once and he treated me so well. I mean, it's definitely worth it. If you have not registered for Monaco, do it for this lecture. It will be worth it. With this, Jan, I will leave you to your evening. And I will say thank you all around the world for listening. We will see each other in 2 weeks in Monaco. We'll see the whole community. Everyone who is interested, again, come back to this YouTube channel in 4 weeks. We're going to have another Just Ask. Maybe Jan is also listening and asking questions. Let's see. With this, all around the world, good night on behalf of the EAO. Thanks again to Jan Cosyn, and see all of you in 2 weeks in Monaco. Ciao, ciao, good night.
Bye, thank you.